So first off, what is consciousness? Consciousness is the awareness of objects and events in the external world and of our own existence and mental processes at any given time. What we are referring to is the idea of our awareness of both internal and external events, feelings, ideas, etc. We consider consciousness to be personal in that it's subjective, it's selective, so we can choose what we think of at any given time. It is continuous in that it never stops, and it's always changing. Theorists consider consciousness to be a hypothetical or a psychological construct. It is believed to exist or occur, but we cannot directly see it or we cannot directly measure it. Consciousness can be divided into two main states of consciousness, and we can see how these are divided on a continuum over to our right. So our states of consciousness refer to our level of awareness, of how much information we take in and respond to at any given time. So for example, the level of awareness we might experience in normal waking consciousness in terms of how much information we take in and respond to would be vastly different to the level or amount of information we are aware of and take in when we are in a coma or asleep, for example. Each of these states are in a continuum in so much as there's actually no distinct boundaries to indicate where one state begins and the other one ends, and that's why it's on this continuum. We do divide the continuum into two main states, as I've said before, and they are vastly different in terms of their characteristics, which we'll talk about in a moment. Normal waking consciousness, or NWC, is the state of consciousness we experience when we awake and aware of our thoughts, feelings, and perceptions from both internal events and the surrounding environment. In comparison, an ASC, or an altered state of consciousness, is any state that is distinctly different from normal waking consciousness. We have a ton of ASCs. So we have things like daydreaming. We have things like being asleep, being hypnotized, being a drug-induced state, so on and so forth. So I've talked about how SOC is a hypothetical construct. While that is the case, it still doesn't stop researchers from trying to measure the different states of consciousness that we are in and compare them in terms of their characteristics. So we measure states of consciousness through four means. These data collection methods can be either subjective or objective. It's really important that you have an idea or an understanding of the strengths and limitations of both of these measures. So for example, subjective measurements are collected through personal observation. They are good because they provide detailed data and they can provide insight into unobservable mental processes like our dreams and our quality of sleep. They're problematic, however, because they're based on personal judgments and therefore difficult to measure and compare. They're also often influenced by bias, and so the data can be skewed. On the other hand, objective measures are measurements of behaviour collected under controlled conditions. Really good examples of this are our physiological measurements and speed and accuracy. The good things about objective measures are that they are easy to measure and compare. They minimize bias and they are accurate and reliable, and therefore they allow for replication to occur easily. The problem is that they can lack detail and they can lack validity due to artificiality. That is, if you're asleep in a sleep laboratory or if you're hooked up to an EEG, EMG, it can actually interfere with your normal sleep-wake cycle or your sleeping pattern, and so the data you provide may actually be skewed. So examples of subjective measures are video monitoring. They use infrared cameras to use infrared lights and operate silently to allow footage to be seen and taped in the dark without disturbing the sleeping participant. So that is our definition. We can use them in a sleep lab or in the person's own home. They observe observable behaviour, things like rolling over, sleep talking, sleepwalking, and they have some strengths and limitations attach to them, which you should have an idea of. The other example of a subjective measure is a self-report. These are statements and answers to questions made by the participant concerning their thoughts and feelings through questionnaires, sleep diary entries, or interviews. They share the personal experience of sleep, things like dreams, the quality of sleep, how refreshed they feel in the morning. Again, there are strengths and limitations that you should know. Our examples of objective measures are measurements of speed and accuracy and physiological measures. So measurements of speed involve response or reaction time to a stimulus. For example, the time taken to see an unexpected stop sign and slow a car down in a driving simulator. It also involves measurements of accuracy, so the number of correct responses and incorrect responses made by an individual. For example, how correct you are, or your mistakes or incorrect answers on a series of simple mathematical problems, or how accurate you are in shooting sheep in the game Sheep Dash. Again, like the subjective measures, there are strengths and limitations that you need to know. And lastly, we have physiological measures, which are recordings of physiological events such as EEG, EMG, EEG, things like galvanic skin response, which is like how much you sweat, your heart rate, your blood pressure, so on and so forth. Just in terms of the strengths and limitations, it is a good idea to have an understanding of what these are. You also must make sure you're able to justify why they are good or why they are bad. So, for example, physiological measures are good because they are less prone to bias, therefore the data is going to be more accurate and reliable. However, because physiological measures often occur in a sleep laboratory, they might end up skewing the data because when you're asleep in a sleep lab, the environment is artificial and this might change your sleep pattern. More specifically, physiological measures are taken using something called a polysomnogram. Now, this is data collected simultaneously from an EEG, EOG, EMG, and other devices. And so, again, that would be done primarily in a sleep lab. It is really important that you know your definitions for your EEG, EMG, and EOG. They have to be word perfect. These have to be absolutely perfect. So, how can you remember them? Remember that you can use DARE. So, each of these measures detects, amplifies, and records the electrical activity in certain physiological measures. So, for example, an electroencephalograph, EEG, detects, amplifies, and records the electrical activity in the brain as measured by brain waves. What this is going to show us is what state of sleep or what state of consciousness a person is in. We'll look at those brainwaves in a moment in the next slide, but this is a really good way to determine if the person is relaxed, if they're awake and aware, or if they're in certain stages of sleep. So this looks at the state of consciousness they're in. Our electrooculograph, or EOG, is a device that detects, amplifies, and records the electrical activity in the muscles responsible for eye movement. It's never the eyes. The eyes do not produce electrical activity. It's actually the muscles that control them. An EOG is going to determine if a person is in REM or NREM based on their eye movements. If they're in REM, they'll show rapid jerky eye movements. If they are in NREM, they'll show slow rolling eye movements. And lastly, the electromyogram is a device that detects, amplifies, and records the electrical activity of the muscles in the body. Again, this will be good to show what state of sleep, REM or NREM, the person is in. With these measures, it's really important that you're responding to the level of electrical activity, whether it's high or low, and then you would justify why that is the case. For example, electrooculogram will detect a high level of electrical activity in REM sleep. That is because the eyes or the eye muscles are involved in rapid jerky eye movements. In NREM sleep, an EOG will detect a low level of electrical activity because of the slow rolling eye movements that are characterized by NREM. In relation to our electroencephalograph, it is important that you know and understand the 4 different brainwaves in relation to states of consciousness. Before we begin talking through the 4, it's important for you to understand what amplitude and frequency mean. So if we have a brainwave here, not a very good one, the frequency means how fast the brainwave is going. So this brainwave here would kind of be slow. So if it's fast, it's going to kind of look like this. Amplitude means that it's like large. So it's looking at the difference in size between the peaks and the troughs. So these are the peaks, these are the troughs. So it means how large they are. So all brainwaves are a combination of frequency and amplitude, and they differ. Each of these differences indicate, I suppose, what state of consciousness a person is in. We have 4 different brainwaves. We have beta, alpha, theta, delta. So beta looks like this. So they're very small, but they're very fast. So they have a low amplitude and a high frequency. We often see beta brainwaves in normal waking consciousness when we are awake and aware. When we become deeply relaxed, this is when we will start to go into alpha, or we will experience alpha waves. As you can see from the brainwave here, they're slightly larger than beta, but they're also slightly slower. So we would say that they have a low amplitude, but higher than beta. So low but higher than beta. And a high frequency, but lower than beta. So it's important in your alpha to compare to beta, because they're not really that dissimilar. Theta waves are indicative of sleep. So whenever you see theta waves, you'll know that we are definitely asleep. So in terms of our amplitude, for theta waves, we're going to have mixed high and low, and you can say that. In terms of the frequency, it will be medium. And lastly, we have delta waves. Delta waves are when we experience deep sleep, and this is when we're normally restoring our body. And that is why, because of those delta waves. Delta, as you can see here, are large, but they're quite slow. So we have a high amplitude and a low frequency. It's really important that you know how to describe these brain waves, and you know whenabouts they occur in terms of SOC. You will not ever have to draw a brain wave, but you may have to identify them in an exam or a SAC. The next thing that you need to know is the effect of drugs on brainwaves. Now, the effect of drugs on brainwaves are probably measured using those measurement devices that we talked about earlier. Primarily, you might look at things that are more objective, so things like physiological responses, so things like EEG, EMG, so forth. You might also look at measurements of speed and accuracy. So you might consider what kinds of things you would see in these 2 measures when you are under the influence of a stimulant or a depressant. So a stimulant is going to increase activity in the central nervous system and the rest of the body. Examples of drugs are things like caffeine, nicotine, cocaine, ecstasy, amphetamines. And what they're normally going to do is they're going to increase beta wave activity, so remember, awake and aware, and decrease delta, alpha, and theta activity. So what we're looking at here is increase in beta, so being awake and aware. So in terms of increase in beta, obviously our EEG will show an increase of beta waves. We may not see any changes in terms of our EMG, EOG. In terms of speed and accuracy, because we are more awake and aware, what might we find in terms of those measures? Maybe we're going to have increased speed and accuracy. In terms of a depressant, This will decrease activity in the central nervous system and the rest of the body. Examples of this might be things like alcohol, tranquilizers, sedatives, things like benzodiazepine, heroin, morphine, codeine. What this is going to do is this is going to reduce beta wave activity and increase delta, alpha, and theta activity. So what we're more likely to see here is an increase in relaxation, so more likely alpha. So in terms of our EEG, again, we'll see an increase in alpha. We may see a slight decrease in EMG given that we're relaxing. In terms of our speed and accuracy, we maybe will have decreased results on these measures given that we are less awake and alert. When we compare ASCs and NWCs, we're looking at how these two states are distinctly different from each other. We can look at how they differed in terms of our physiological measurements, so things like EEG, EMG, etc. But we can also look at the differences in terms of psychological characteristics. So all of these are psychological. In terms of these psychological changes, it's important that you know how to compare ASC and NWC in terms of these types of characteristics. And when you do that, you would need to make sure that you identify the characteristic, you describe it, and you give an example based on the scenario that you may be given. You may also be asked why certain ASCs, like sleep and drug-induced states, are ASCs. So what I would recommend if I were you is learning maybe about 3 of these, knowing them really well, so you can apply those 3 to each of these points that I've just outlined for you. When doing so, I would recommend you use things like perceptual and cognitive distortions, emotional awareness, self-control, and time orientation. They are often easier to compare and describe than the 3 above. It is also important that you understand the difference between selective and divided attention. So, selective attention refers to the limitations placed on how much we can focus on at any given moment. So, if you are sitting in the SAC and you're obviously doing a SAC, you're so focused on doing that task that you may not notice the person coughing beside you. This is different to dividing your attention, which is the ability to distribute our attention and undertake 2 or more activities simultaneously. So for selective, we're using all of our attention, and in divided, we are using some on 2 or more tasks. We need to understand how these relate to controlled and automatic processes. A controlled process is going to require a high level of conscious awareness, attention, and mental effort. We can only do one at a time, so this is why we tend to use selective attention when engaging in controlled processes. An automatic process requires little conscious awareness or mental effort and does not interfere with the performance on other activities. We would be able to use divided attention when engaging in automatic processes. So, for example, a controlled process is probably learning to drive for the first time. You use all of your attention, so selective attention, in engaging in that task. If you, for example, walking and talking with a friend, neither walking or talking uses a high level of attention, so you could divide your attention between those 2 automatic processes. A great example of an altered state of consciousness is sleep. So sleep is a naturally occurring altered state of consciousness that is accompanied by a number of physiological effects and levels of alertness. I'm sure you're aware that sleep is a pretty significant ASC given that we spend 1/3 of our total life asleep. A sleep cycle is a great example of an ultradian rhythm, in so much as it lasts less than 24 hours. We know that sleep is subdivided into a period of NREM and REM sleep. We normally go through about 4 to 5 cycles during 8 hours of sleep, and these cycles last 90 minutes. If we were to look at a hypnogram, so this bad boy over here, we would see that sleep goes through a pretty unique pattern. So it doesn't go 1, 2, 3, 4, REM, and then so on and so forth. The way it works is it goes stage 1, 2, 3, 4, 3, 2, REM. Then it should normally go again 2, 3, 4, 3, 2, REM. Now, if you have a look over here, you'll notice that it doesn't actually follow that pattern through the whole stage of sleep or through the night. That's because as sleep progresses, we spend a lower proportion of time in NREM, 3, 4, and a higher proportion of time in REM. So you'll be able to see up here that we have way more REM, or a higher proportion, than we do at the start of the night, and a lower proportion, so none down here, of 3 and 4 NREM than we do at the start of the night. Now, the reason we say proportion and not amount is because the amount of sleep that is had through different stages of the lifespan is different, and proportionally, everybody has that same pattern. The other thing that we should note is that we also go through 2 transitional stages of sleep. So at the start of the night, and my hypnogram is looking pretty messy, but at the start of the night you can kind of see here, we have the hypnagogic stage. So that goes into sleep. And at the end of the night we have the hypnopompic stage. And that goes out of sleep into wakefulness. So they are part of stage NREM1, but they are transitional, so going in and out of sleep. Now, it's not necessary to understand, I suppose, all of the explicit changes and characteristics of all of the stages. So more explicitly, stages NREM 1, 2, 4. What I would like you to know is the key differences between NREM and the REM stages of sleep. So NREM sleep, we spend the most of the time asleep in this stage, so 80% in comparison to 20% spent in REM sleep. REM sleep is thought of as quiet sleep. Now that's because our body is relaxing as we go from stages 1 to 4. So in NREM sleep, we see slow rolling eye movements, and they become more and more rare as we go from 1 to 4, so into deep sleep. We have a progression of brainwaves, so alpha, theta, and delta. Again, we're more likely to see delta in that deeper stage of sleep. And again, as we go from stages of 1 to 4 NREM sleep, our muscles are going to relax. So we're going to see less muscle movement as we progress through those stages. Physiological responses like heart rate, body temperature, blood pressure, all decrease as we go from 1 to 4. The reason everything decreases and our body relaxes is because NREM sleep is thought to replenish our body. So it does things like help us to recover from fatigue, repair body tissues, and allow growth to occur. We tend to have a higher proportion at the start of the night as compared to the ends of the night. We do have dreams, but we are unlikely to remember them. In comparison, REM sleep is considered to be a paradoxical sleep. And that's because while we have beat-like waves with a sawtooth pattern, indicating that our brain is awake and aware or active, we have things like muscle atonia or cataplexy, so we're actually experiencing paralysis. We also have rapid jerky eye movements in this stage of sleep, and that's why they call it REM sleep. So REM sleep is characterized by rapid jerky eye movements. So again, in combination with the rapid jerky eye movements, the active brain waves, as well as the muscle atonia or cataplexy, that's why we tend to think of REM sleep as paradoxical. So dissimilar to REM sleep, our physiological measures increase, so our heart rate will increase, etc. And this is thought to be because our REM sleep replenishes our mind, so that's why our brainwaves are more active. Because our brainwaves are more active, or we're more alert, I suppose, it is more common for people to report dreaming, and you're more likely to get nightmares. We see a higher proportion of REM at the ends of the night rather than the start. So the next thing we have to consider is the purpose of sleep. So why? There are two theories that we need to be aware of, and you need to know the description, evidence, and criticisms for both theories. The first theory that we'll look at is the restorative theory of sleep. So the restorative theory suggests that sleep is vital for replenishing and revitalizing the physiological and psychological resources depleted by our waking activities. Therefore, sleep keeps the mind and body functioning at an optimal level. So this theory of sleep explains why sleep is necessary. For this definition, it's really important that you are not using the same word as restorative, so use the words replenish or revitalize. When you're discussing this theory of sleep, you must make sure you're mentioning the physiological and psychological resources that are revitalized by our REM sleep and our NREM sleep, or vice versa. So remember, NREM sleep revitalizes the physiological resources, and REM revitalizes the psychological resources. So how do we know this? We know that NREM revitalizes the physiological resources because REM gives the body time to recover by replenishing resources like restoring hormones, allowing damaged cells to be repaired, and allowing various muscles to be detoxified. So we know this because when people are sick, they sleep more because they're spending all of their energy fighting that illness, and that's why they need more sleep. We also feel refreshed after we sleep. The evidence that we use for this particular theory, I suppose, so more specifically for NREM sleep, is marathon runners. So they did a study with ultramarathon runners, and they had participated in a 92-kilometre road race. What they found was that they slept 90 minutes longer and doubled their deep sleep for 2 nights after running the marathon. So what they actually found was that marathon runners had a higher proportion of NREM sleep after that immense or intense physical activity. In terms of REM sleep, we know that REM sleep allows us to consolidate memories. And so that's why babies tend to have a lot of REM sleep. Because they're learning so much, they need extra time in REM sleep in order to consolidate everything that they've learnt. We also know that sleep enhances mood. More specifically, if we are deprived of REM sleep, we tend to be more grumpy, and that tends to lead to things like anxiety or mental disorders, etc. In terms of our criticisms, you must make sure your criticisms match your evidence. So we've given the evidence of the marathon runners, and so your criticisms should reflect that. So our criticism is that it's not really been conclusively established in a cause and effect way what is actually being restored in sleep. So we found this evidence to suggest that if we have lots of exercise, we're going to have a high proportion of time spent in NREM on subsequent nights. However, people who are less active, so those in wheelchairs, bedridden, just lazy, they actually still experience the same amount of NREM sleep than those who are maybe, able, they're not on wheelchairs, they're not lazy. So that kind of refutes or is a criticism of that theory of sleep. The other theory of sleep that we have is the evolutionary theory. Now, this proposes that we undertake periods of inactivity or sleep when we don't need to engage in activities that are important for our survival. When we discuss activities that are important for our survival, what we are primarily talking about is eating, hiding from predators, and our ability to conserve energy. So this theory is actually explaining when and why certain animals sleep. In terms of our evidence, we know that this is a thing because there's a pattern that demonstrates how an animal's energy requirements and number of predators correlates with sleep time. For example, cows only sleep 4 hours per day because they require the rest of their time to graze. Another example is animals with few natural predators like lions, tigers, and gorillas may sleep a lot because they don't have to be wary of the predators. However, large prey animals, so cows, for example, sleep a lot less because they are more exposed in their environment and need to be ready to escape from predators. And so that's why they have less time asleep. The problem is that we often consider sleep to be kind of protective. However, the problem with that is that when animals are asleep, they're more vulnerable to predators due to their reduced awareness of their external environment. So, for example, it is suggested that humans sleep at night because we're more prone or we're more vulnerable to animals because we can't see so well in the dark. However, with this criticism, this is suggesting that when we are asleep, we're even more vulnerable because we have reduced awareness. So that kind of like flies in the face, or it contradicts the evidence to support the theory. The next thing that we're going to look at is the sleep-wake shift in the lifespan. So you will be familiar with this table or this graph. And so you will know that as our age increases, our total sleep time will decrease, as we can see here. So we have less time as we go through the lifespan. And we also have initially a decrease in REM sleep, but then it plateaus. The other pattern that you should be aware of is as we get older, we have a decrease in the amount of NREM 3 and 4 that we have. And so this means that as we get older, we tend to have more lighter sleep. For this particular dot point, it's really important that you understand how infants, children, adolescents, adults, and the elderly all differ in their respective sleep patterns. Now, what you would generally be asked to do for something like this is to compare them, or you might look at something like a hypnogram. And so when you are looking at these kinds of things, either comparing them or looking at a hypnogram, you would do so using a certain set of characteristics. Now, if you were just comparing them, you can certainly just talk about the total sleep time that they might have. You might also look at the proportion of REM and the proportion of NREM 3 and 4. If you are looking primarily at a hypnogram, you are not looking at the total sleep time. Do not do that, okay? Because most hypnograms will not tell you how long they're spending asleep. It will generally be over like 9 hours for both, let's say, infants and adults. But we know infants have more than 9 hours of sleep. So when looking at hypnograms, you're looking primarily at the proportion of REM, looking at the proportion of NREM 3/4, and the amount of awakenings. Sleep is a really good example of a biological rhythm. A biological rhythm are naturally occurring patterns of cyclic changes in a bodily function or state that repeats itself over time. So examples of biological rhythms are things like body temperature, blood pressure, blood sugar level, etc. So we know with our body temperature that it is on a 24-hour cycle. So if we were to look at our body temperature through a 24-hour cycle, we would see that it actually dips and then increases at certain points of the day. So for example, it will dip and become lowest from between 2 to 4 a.m. and that's why you tend to feel cold at those points in the night. Examples of biological rhythms are circadian rhythms and ultradian rhythms. So a circadian rhythm involves changes in bodily functions or activities that occur as a part of a 24-hour cycle. So this includes your sleep-wake cycle, alertness, body temperature, etc. So it's endogenous, so it's based on internal biological factors, such as the secretion of melatonin that is regulated by the suprachiasmatic nucleus, but it's also influenced by environmental time cues like light. And so those two factors, biological factors and the environmental time cues, they actually interact through the mechanism that is regulated by the suprachiasmatic nucleus. So what actually happens is that the suprachiasmatic nucleus, or the SCN within the hypothalamus, registers the amount of light that is in the environment, and that occurs via light sensors in your eyes and at the back of your knees, but do not talk about that. What it then does is it signals to the pineal gland to secrete more or less melatonin. Now, if the pineal gland receives information that we have a high level of light in the environment, then this is going to secrete less melatonin because you need to be awake. If the pineal gland receives information that there is low light, then this is going to secrete high levels of melatonin to induce sleepiness. Now, another rhythm that is linked to the suprachiasmatic nucleus is actually the ultradian rhythm. So this is changes in the bodily functions that occur as a part of a cycle that is shorter than 24 hours. Sleeping is an ultradian rhythm because it involves 90-minute cycles. The biological clock, or the circadian rhythms, and the suprachiasmatic nucleus becomes really important when we consider circadian phase delay disorders. Now, these are examples of dysomnias. They involve disruptions due to a mismatch between an individual's sleep-wake pattern and a pattern that is required. So what's actually happening is your biological sleep-wake pattern is actually out of sync with the external environment. This is caused by intrinsic causes, so medical conditions, your age, and also extrinsic causes, so things like jet lag or shift work. What this tends to lead to primarily is sleep deprivation, which we'll look at later on. In terms of these circadian phase delay disorders, you need to be aware of three. So the shift in the adolescent sleep-wake cycle, shift work, and jet lag, in relation to the description, why they occur, and how that affects sleep. So let's start with adolescents. We know that adolescents need about 9 hours of sleep. We also know that they tend to become night owls because their sleep-wake pattern shifts towards the evening and they want to sleep in the morning. So what's actually happening is the adolescent sleep pattern is shifting forwards. Rather than going to bed or feeling sleepy at 10 o'clock, they actually feel sleepy later on, so forward, at like midnight. There are two reasons for this. So the first one, and the one that you're going to be most likely asked about, are these biological causes. So we know that melatonin induces sleep. Now, you always talk about what melatonin does. Always tell the examiner that it induces sleep. So we know that in an adolescent, melatonin is released 1 to 2 hours later, and therefore adolescents tend to feel tired later than they normally would. So when you're talking about biological causes, talk about what melatonin is, how it's secreted later, and what the effect is on the adolescent feeling tired. The other reasons, of course, are social reasons, so things like homework demands and school. So because adolescents are spending so much time doing their homework and going out, they actually get to bed much later than they need to in order to get that 9 hours of sleep. So because an adolescent on a school day can't sleep in to get that required 9 hours of sleep, they need to get up at like 6 or whatever, it means that adolescents are really, really sleep deprived. What this may lead to, maybe more so for some than others, is that on the weekends, adolescents tend to sleep longer than they do on weekdays, which may mean that they're trying to catch up on their sleep. The other social reason that we need to consider are things like the internet or phones, which actually has a link to biological things as well. So we know that the light emitted from electronic devices like your phone, your laptop, your iPad is actually bright enough to prevent the release or inhibit the secretion of melatonin. So what this means is that this will cause people to feel sleepy later than normal, even more so than they already do, and again contributes to that shift in the sleep-wake cycle. The next shift that we'll talk about is shift work. Now, this obviously involves hours of paid employment that are outside the period of normal working day and involve rotating schedules. What's actually happening is there is a mismatch between the worker's sleep-wake cycle and the environmental cues. So what's actually happening is shift workers normally wake when their melatonin is high, so they should be asleep, and they want to go to sleep when melatonin is low, and therefore they should be asleep. So what's actually happening there is a desynchronization between their sleep-wake cycle and their environmental pattern, or the environment. So what this can actually lead to is 2 hours less sleep of a lower quality than a normal worker. What can happen here is it can lead to symptoms like insomnia and excessive sleepiness. So essentially what we're talking about is sleep deprivation. Now, if that is chronic, so long term, what that might mean is there is a long-term decline in their mental and physical functioning. The last circadian phase delay disorder that we're going to talk about is jet lag. So this is a sleep disorder due to a disturbance in the circadian wake cycle caused by rapid travel across multiple time zones. Now again, what is happening is that the intrinsic factors are not matching our internal body clock. Now this depends on the number of time zones crossed, the direction of travel, the duration, and the quality of the flight. What normally happens is it takes a few days for your internal body clock to recognize your new time zone and resynchronize your sleep-wake cycle. We actually have a number of things that need to readjust when you actually have jet lag. Things like temperature and hormonal rhythms take about a week to adjust. Now, because there is this desynchronization between your body clock and extrinsic factors, what it can lead to are things like reduced daytime alertness, impaired concentration and cognitive performance, digestive problems, and feelings of malaise. Circadian phase delay are examples of sleep disorders. Sleep disorders occur when a sleep disturbance regularly disrupts sleep and causes distress or impairment in everyday functioning. So what we're suggesting here that a sleep disorder is a condition that consistently disrupts a normal NREM sleep cycle. We divide our sleep disorders into two primary categories. So we have dysomnias, which are here. So they produce difficulty initiating, maintaining, and timing of sleep, or parasomnias. So these are the occurrence of inappropriate physiological or psychological activity during sleep. Despite what the textbook tells you, you only need to know one example of dysomnias and one example of parasomnias. The example that you need to know for dysomnias is sleep onset insomnia. So those with dysomnia normally suffer from changes in the quantity or the quality of their sleep. More explicitly, sleep onset insomnia is a disorder resulting in a persistent inability to fall asleep at the beginning of the night. We have other kinds of insomnias, which means you wake up and you can't go back to sleep in the middle of the night. Sleep onset insomnia may be acute or it may be chronic, so it may be short-term or long-term. And it's characterised by these explicit symptoms. So failure to fall asleep within 30 minutes, reduced amount of total sleep, feeling tired during the day, may be irritable, have mood disturbances, feel fatigued, so on and so forth. This is normally caused by a range of causes or factors, and they can be psychological, behavioural, or physiological, or biological. Just make sure you know a few of those. You don't have to extend on them, you just need to know what they are. We know that in order to treat sleep onset insomnia, we would use CBT or cognitive behavioural therapy. As a direct comparison, a parasomnia is not so much about maintaining sleep or falling asleep. It's actually about explicit events that occur during sleep that can disrupt the quality of sleep. Now, unlike insomnia or dysomnias in which we are aware of the issue, parasomnias normally are characterized by the fact that people are unaware of the effects. So things like sleepwalking, night terrors, you're generally not aware of them. So the example that you need to know, of course, is sleepwalking or somnambulism. So this is when a person walks and does routine tasks or activities while asleep, and hence are aware of them. It tends to last up to 15 to 30 minutes, and it occurs in the first third of sleep. Let's change that. And now, of course, that's because as we go on during the night in terms of sleep, we actually have a lower level of NREM 3 and 4 sleep. And we know that we can't sleepwalk during REM because we are in cataplexy. So again, you need to know the symptoms, and they include things like movements often occur in a confused and clumsy manner, but they maintain coordination. They may perform routine, well-learned activities or socially inappropriate behaviours, and sleep talking may occur. They tend to be unresponsive, and it's difficult to wake them. It's not dangerous to wake them, but they will be disorientated and confused. Again, you just have to have a general idea of the causes, which are things like they're more common in times of stress, and it's partly hereditary. So if your mum or dad has sleepwalking that they might engage in, it actually means that you're more likely to engage in sleepwalking too. In terms of treatments, there's actually no explicit treatment for sleepwalking, but having good sleep hygiene can actually help. So going to bed on time, sleeping in a cool environment, not drinking any stimulants before you go to bed, so on and so forth. It's really important that we know and understand how to manage some sleep disorders. So that's why in this dot point we're looking at interventions for sleep disorders. There are two that you need to know. We need to know cognitive behavioral therapy for treating insomnia and bright light therapy for circadian rhythm disorders. CBT is a type of psychotherapy, and it tends to be short term, so it doesn't last very long, but is a very effective treatment that uses cognitive and behavioral methods to help people change unhelpful or unhealthy thought processes, feelings, and behaviors. The assumption is the way that people feel and behave is a product of the way that they think. So CBTI, or cognitive behavioral therapy for insomnia, focuses on the causes of the sleep problem and on changing those unhelpful behaviors. It does this through two different components, through cognitive therapy and behavioural therapy. You must ensure that you talk about the cognitive part and the behavioural part separately, not as the same answer. So they have to be separate dot points because they do different things. So in cognitive therapy, the therapist will help to identify and replace unhelpful thoughts with more realistic and positive thoughts about sleep. The way they would do that is they would have the participant to use a sleep diary to record their tiredness and negative thoughts about sleep. Then they would provide the patient with accurate information about sleep and do things like re-educate them about their maladaptive thought patterns. The behavioural therapy involves the therapist teaching strategies to change or remove unhelpful behaviours and develop better sleeping habits. What they might use is classical conditioning or operant conditioning principles to help them do this, or they would actually educate them in terms of sleep hygiene. So sleep hygiene means you may be doing things that are maybe not so conducive to sleep in your bedroom or your bed. So like eating, watching TV in bed, going to sleep when your curtains are open so it's quite light out. So in order to change that, what you might do is make sure that you're asleep in a dark environment, make sure it's cool, make sure you don't eat in bed, make sure you don't ingest any caffeine prior to sleep because that can also inhibit your sleep. So remember, for CBT, we're looking at two different therapies, cognitive therapy and behavioural therapy. Bright light therapy for circadian rhythm disorders is timed exposure to the eyes to intense but safe amounts of light. So what this is going to do is it's actually going to reset the biological clock and shift someone's circadian sleep-wake cycle to a more appropriate schedule. Depending on the timing, this can help either adolescent sleep-wake cycles, shift work, or jet lag. So what the person would do is they would be positioned so the light hits their eyes, and they would sit there for an amount of time, and that can range from between 30 minutes to 2 hours. But they can do things that they normally do, like, play on the computer, do some homework, whatever. It's really important that the person is exposed to light at the right time of the day, the right intensity, and for the right amount of time. So for example, if you're an adolescent and you have phase delay, you would be exposed to light in the morning. If you're a shift worker, you will be exposed to light at night. And jet lag would actually depend on if you are going east to west or west to east. Our last little dot point is how these disorders can affect us in terms of our sleep and our functioning. So this is why it's really good to talk about the effects of total and partial sleep deprivation. Now, yes, it is true that we are often sleep deprived when we have sleep disorders. However, you don't have to have a sleep disorder to be sleep deprived. Most of us actually are sleep deprived because our lives are so busy these days. So sleep deprivation is a state that is caused by inadequate quality or quantity of sleep. Now, this can be voluntary or involuntary. We have total sleep deprivation, which involves not having any sleep at all for a short or long period, so generally no sleep in a 24 or a 48 period. And partial sleep deprivation involves having less sleep than what is normally required, either in quality or quantity. So you'll probably have some sleep in a 24-hour period, but it won't be enough to meet your needs. In terms of total sleep deprivation, they've done studies to compare 24 hours of sleep deprivation to our blood alcohol level. And what they've actually found is that 24 to 28 hours of sleep deprivation is the equivalent of a BAC of 0.1, which means people are 7 times more likely to have a car crash. In these studies between sleep deprivation and legal BAC, theorists or researchers have looked at cognition, they've looked at concentration, and they've looked at mood. what they've actually found is that in all of these things, sleep deprivation and legal BAC is exactly the same. So, for example, in sleep deprivation, as the hours awake increase, performance on cognitive tasks, so things like reaction, memory, attention, will decrease. And as BAC increases, cognitive tasks such as memory, logic and reasoning, problem solving also decrease. So we know that as sleep deprivation and legal BAC increase, our cognition will actually decrease. This is similar for concentration. So as sleep deprivation and legal BAC increase, there is a decline in concentration. The only thing that is slightly different between sleep deprivation and legal BAC is mood. In sleep deprivation, the more sleep deprivation we have, the more our positive moods tend to decrease. So we tend to have a lower mood overall, so it just tends to be low. In terms of our BAC, our emotions tend to be heightened, exaggerated, or intensified. They tend to fluctuate a lot more than they do in sleep deprivation. Lastly, it's important to be aware of the effects of partial sleep deprivation. Now, most of us are sleep deprived, and it tends to be partial sleep deprivation. So it's really important for us to understand the effects of this partial sleep deprivation. So we have affective or emotional changes, we have behavioural, and we have cognitive. So we call it the ABC of sleep deprivation. In terms of emotional changes, we tend to have amplified emotional responses, we have mood changes, poor emotional perception, we become more overwhelmed when confronted with stresses. In terms of behavioural, we have sleep inertia, which is those feelings of grogginess when you wake up. We have sleep disturbances, slower reaction time, impaired behaviour control, which means you generally just get naughty when you're asleep. So you become naughty, and that's the case with all of you. And we have reduced motor coordination. With cognitive changes, we have lapses in attention, and this can lead to something really important. So more specifically, we actually have problems with simple monotonous tasks when we are sleep deprived. So we tend to perform worse on simple tasks than we do on complex tasks when we are sleep deprived. We also have problems with problem-solving, decision-making, and errors in judgment. We tend to think irrationally and have impaired learning and memory. In terms of how to recover from your effects of sleep deprivation, you only need one night to recover from all of these effects. So that is it for the content that you need to know for the SOC. If I were you, I would make sure I was doing all of those practice SACs and applications that you have been given, because they are all very important and very relevant for the SAC that is happening on Wednesday.